Welcome to 2-Minute MRCP. Asthma is one of the most common respiratory conditions encountered in clinical practice and a favorite topic in the MRCP exam. In this video, we'll cover 5 essential areas: asthma severity classification, investigation, acute asthma management, long-term maintenance therapy, and occupational asthma. Let's begin with acute asthma severity classification. The British Thoracic Society classifies acute asthma into 4 categories: moderate, severe, life-threatening, and near-fatal asthma. Moderate asthma is characterized by a peak expiratory flow rate, or PFR, between 50 and 75% of the patient's best or predicted value. The patient can speak normally, the respiratory rate is less than 25 breaths per minute, and the pulse is below 110 beats per minute. Severe asthma is present when the PEFR falls between 33 and 50%. Patients are unable to complete sentences in one breath, the respiratory rate exceeds 25 per minute, and the pulse is above 110 beats per minute. Life-threatening asthma is diagnosed if any one of several features is present. These include a PEFR below 33%, oxygen saturation below 92%, a normal arterial carbon dioxide level between 4.6 and 6.0 kilopascals, a silent chest, cyanosis, feeble respiratory effort, bradycardia, arrhythmias, hypertension, exhaustion, confusion, or coma. A patient with even one life-threatening feature must be treated as having life-threatening asthma. Near-fatal asthma is the most severe category. It is characterized by a raised arterial carbon dioxide level and/or the need for mechanical ventilation with high inflation pressures. Additional investigations are also important. Arterial blood gases should be performed in any patient with oxygen saturation below 92%. A chest X-ray is not routinely required, but should be considered in cases of life-threatening asthma, suspected pneumothorax, or failure to respond to treatment. Now, let's move on to acute asthma management. All patients with life-threatening asthma must be admitted to hospital. Patients with severe asthma should also be admitted if they fail to respond to initial treatment. Other important admission criteria include a previous near-fatal asthma attack, pregnancy, an attack occurring despite oral corticosteroid therapy, or presentation during the night. If the patient is hypoxemic, oxygen should be given immediately. Acutely unwell patients should initially receive 15 liters per minute via a non-rebreather mask. Oxygen is then titrated to maintain saturations between 94 and 98%. Bronchodilation is the cornerstone of acute management. High-dose inhaled short-acting beta-2 agonists, such as salbutamol or terbutaline, should be administered promptly. In patients without life-threatening features, these can be delivered using a pressurized metered-dose inhaler with spacer, or via an oxygen-driven nebulizer. In life-threatening asthma, nebulized bronchodilators are preferred. All patients should receive corticosteroids. Prednisolone 40 to 50 mg orally once daily should be given for at least 5 days, or until recovery. Patients should continue their usual inhaled corticosteroids during this period. Nebulized ipratropium bromide should be added in severe or life-threatening asthma, or if there is inadequate response to initial bronchodilator and steroid therapy. Intravenous magnesium sulfate is commonly used in severe or life-threatening attacks, although the evidence is mixed. Intravenous aminophylline may be considered after discussion with senior medical staff. Patients who fail to improve require escalation to critical care. Options include intubation, mechanical ventilation, and in selected cases, extracorporeal membrane oxygenation, or ECMO. Before discharge, the patient should be stable on their discharge medication without requiring oxygen or nebulizers for at least 12 to 24 hours. Inhaler technique must be checked and documented, and the PFR should be greater than 75% of the patient's best or predicted value. Next, let's discuss long-term maintenance management in adults. The 2024 NICE, British Thoracic Society, and SIGN guidelines introduced a major shift in asthma treatment. Traditionally, patients started with a short-acting beta-2 agonist, or SABA, and then stepped up to inhaled corticosteroids. However, current guidelines now favor combined inhaled corticosteroid and formoterol inhalers from the outset. Step 1 involves low-dose inhaled corticosteroid and formoterol used only when required. This is known as anti-inflammatory reliever, or AIR, therapy. If the patient presents with frequent nocturnal symptoms or a severe exacerbation, low-dose maintenance and reliever therapy, known as MART, should be started immediately. Step 2 is low-dose MART. The same inhaler is used both regularly and as needed for symptom relief. Step 3 involves moderate-dose MART. Step 4 requires reassessment. Fractional exhaled nitric oxide, or FeNO, and blood eosinophil count should be checked. If either is elevated, referral to an asthma specialist is recommended. If both are normal, consider adding either a leukotriene receptor antagonist, such as montelukast, or a long-acting muscarinic antagonist, such as tiotropium. If one option is ineffective, discontinue it and trial the alternative. Step 5 is specialist referral for uncontrolled asthma despite moderate-dose MART, plus trials of both an LTRA and a LAMA. Now, let's cover occupational asthma. Occupational asthma should be suspected when symptoms worsen at work and improve on weekends or holidays. Isocyanates are the most common cause. They are frequently encountered in spray painting and foam molding industries. Other important triggers include platinum salts, soldering flux resin, glutaraldehyde, flour, epoxy resins, and proteolytic enzymes. Diagnosis is supported by serial peak expiratory flow measurements recorded both at work and away from work. Any patient with suspected occupational asthma should be referred to a respiratory specialist for further assessment and management. Finally, let's move on to asthma investigations. NICE revolutionized asthma diagnosis by shifting the emphasis away from purely clinical judgment and toward objective testing. A key investigation is fractional exhaled nitric oxide, or FeNO. Nitric oxide is produced by inducible nitric oxide synthase in inflammatory cells, particularly eosinophils. Elevated FeNO therefore reflects eosinophilic airway inflammation. Spirometry and peak flow variability also remain essential components of asthma assessment. All patients aged 5 years and older should undergo objective testing. In children under 5 years, diagnosis remains clinical. For patients aged 17 years and above, always ask whether symptoms improve on days away from work or during holidays. If they do, consider occupational asthma and refer to a specialist. Adults should undergo spirometry with bronchodilator reversibility testing, as well as FeNO measurement. For children aged 5 to 16 years, spirometry with bronchodilator reversibility testing is recommended first. If spirometry is normal, or if obstructive spirometry does not show reversibility, then FeNO testing should be performed. Now let's quickly review the important diagnostic thresholds. A positive FeNO test is defined as 40 parts per billion or higher in adults, and 35 parts per billion or higher in children. Obstructive spirometry is indicated by an FEV1 to FVC ratio below 70%, or below the lower limit of normal if available. A positive bronchodilator reversibility test in adults requires an increase in FEV1 of at least 12% and at least 200 milliliters. In children, an increase in FEV1 of 12% or more is considered positive. To summarize, asthma management requires accurate assessment of severity, prompt treatment of acute exacerbations, evidence-based long-term control, and recognition of occupational triggers. Master these principles, and you'll be well prepared for both the MRCP exam and real-world clinical practice. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.